Shock is one of the most time-sensitive, life-threatening emergencies we face in pre-hospital care. This week, we're going to look beyond just low blood pressure and really understand what happens at the cellular and the systemic levels. When you hear shock, what comes to mind? Many immediately think hypotension, but I need you to reframe your understanding right now. Shock is fundamentally a state of inadequate tissue perfusion that leads to cellular hypoxia and impaired metabolism. Let's break this down. Your patients don't go into shock because their blood pressure drops. Their blood pressure drops because they're in shock. And critically, many patients in shock maintain normal blood pressure readings well into their deterioration. At its core, shock represents either impaired oxygen delivery to tissues, impaired cellular utilization of that oxygen, or a combination of both. The oxygen carrier, hemoglobin, can be damaged. Compensated shock is where the assessment gets really tricky. Your patient's body will fight to maintain blood pressure through compensatory mechanisms. These compensatory mechanisms are tachycardia, peripheral vasoconstriction, increased respiratory rate, altered mental status that does not match what's going on with the situation, and this includes severe anxiety. This creates what we call compensated shock, a patient maintaining a normal blood pressure while their tissue perfusion and cellular metabolism are already falling off. By the time hypotension develops, you're dealing with a decompensated shock patient, and your patient has exhausted their physiological reserves. So how do we detect shock before decompensation? Well, look for delayed capillary refill of greater than 2 seconds, cool, pale extremities, and altered mental status, again disproportionate to what's going on, a narrowing pulse pressure, tachycardia that's inappropriate for the context, and an increased respiratory rate without primary respiratory cause. An early sign, if you're working in the hospital, would be decreased urine output that can lead to metabolic acidosis on blood gas. Remember, lactate elevation isn't just a lab value, it's the voice of oxygen-starved tissues crying out for help. The bottom line, treat the physiology, not the number. A normal tensive patient can be in critical shock. The problem isn't just the pump, the pipes, or the fluid, it's the oxygen delivery to the tissues. When you suspect shock, act early, identify the type, address the cause, and support the compensation mechanisms before they fail. Don't wait for hypotension to confirm your clinical assessment already tells you, because in shock, time is tissue, and tissue is life. When we assess patients for potential shock, we're really evaluating a complex interplay of major physiological systems. So let's break some of them down. For adequate oxygen delivery, 3 components must function optimally. Ventilation. The patient must be able to move oxygen into the alveoli and eliminate CO2. This requires a patent airway, adequate respiratory rate, and tidal volume, as well as adequate functional lung tissue for gas exchange. Hemoglobin. As our primary oxygen transport molecule, hemoglobin must be present in sufficient quality and quantity, normal being 12 to 17 grams per deciliter. It also has to be functional, not affected by carbon monoxide. It's got to be properly saturated with an SpO2 of 94% or greater in most cases. And then lastly, cardiac output. The heart must effectively pump oxygenated blood to the tissues. Stroke volume is determined by 3 critical factors. Preload. The volume that stretches the ventricle before contraction. This is governed by the Frank-Starling mechanism, and it's affected by the total blood volume, venous tone, and positioning of your patient. You can assess this through JVDs, peripheral edema, and lung sounds. It's also affected by afterload, which is the resistance that the ventricle must overcome to get the blood out of the left ventricle and into the circulation. This is primarily vascular resistance in systemic circulation, and it's affected by vasoconstriction, vasodilation, vascular compliance, an increase in hypertension, aortic stenosis, or potentially even vascular disease. Contractility, the inherent strength of myocardial contraction that is independent of preload or afterload. It's affected by sympathetic stimulation medications, electrolytes. It can be compromised in cardiomyopathy, myocardial infarction, sepsis. The heart rate must be appropriate for the physiological demand. Should be regular with normal conduction, neither too slow, which reduces output, or too fast, which reduces filling time. The vascular resistance and distribution, the tone must be regulated to direct blood to the tissues with the highest metabolic needs. Must maintain systemic pressure for perfusion and respond appropriately to local and systemic signals. This requires an intact autonomic nervous system, a functional endothelium that's capable of responding to local metabolites, and then the cellular utilization. Here's the clinical pearl that's often overlooked. Even with perfect oxygen delivery, cardiac output, and vascular regulation, shock can still occur if cells cannot utilize the delivered oxygen. This is where cellular dysfunction occurs in septic shock, where the mitochondrial dysfunction prevents oxygen utilization despite adequate delivery. Cyanide poisoning blocks the cytochrome oxidase. These patients can become into severe acidosis, disrupting the processes that allow the oxygen to be able to be utilized. This is why sometimes we see patients with normal or high SpO2s. Elevated lactate, despite normal vital signs, can also be an early indicator of shock. When treating potential shock states, assess all the components. Don't fixate solely on the blood pressure. Consider cellular function, particularly in sepsis or toxicological emergencies. It's critical that you monitor your trends. If you're able to measure a lactate, look for that and track lactate levels. In your assessment and your treatment development, target the specific deficiency. The right intervention depends on which component is failing. It's critical to remember that tissue oxygenation is the ultimate goal of all resuscitation efforts. Understanding these interrelated factors allows you to intervene precisely where the system is failing. Tissue oxygenation is the ultimate goal of all resuscitation efforts. Understanding how these play into each other is critical for success. So let's start with the fundamental concept, resistance. Vessels are arterioles. These are small muscular vessels ranging from 20 to 150 microns in diameter and serve as the primary regulators of blood flow distribution throughout the body. Unlike the larger conduit arteries that transport blood, arterioles have three crucial hemodynamic functions. They control regional blood flow to specific tissues and organs. They determine systemic vascular resistance, and they influence venous return and therefore cardiac preload. The walls of arterioles contain a thick layer of smooth muscle controlled by sympathetic nervous system, local metabolites such as oxygen, carbon dioxide, and hydrogen, specific circulating hormones such as epinephrine, angiotensin II, and vasopressin, and then there are endothelial factors that come into play, in particular, nitric oxide. Here's where the concept gets really interesting in clinical revel. Arterial tone affects hemodynamics in two critical ways. When arterioles constrict, peripheral resistance increases. Afterload on the left ventricle increases, blood pressure tends to rise if the cardiac output is maintained. When arterioles dilate, peripheral resistance decreases, afterload on the left ventricle decreases. Blood pressure tends to fall, again, if cardiac output is maintained. There are also preload effects. This is where many providers miss the connection. Arterial tone significantly influences venous return and therefore preload through blood distribution. When arterioles constrict, blood is squeezed out of the peripheral circulation. More blood returns to the central circulation. Venous return increases, preload increases, therefore stroke volume increases because of the Starling law. When arterioles dilate, blood pools in the peripheral circulation, meaning less blood returns to the central circulation, venous return decreases, preload decreases, stroke volume decreases, resulting in a reduction in cardiac output. Let's apply this concept to several clinical scenarios. Septic shock. In the septic shock, inflammatory mediators cause widespread arterial dilation, resulting in decreased systemic vascular resistance, reducing afterload, blood pooling in the periphery, reducing preload, reduced venous return, resulting in decreased cardiac output despite a hyperdynamic heart. Tissue hypoperfusion despite warm extremities. This explains why fluid resuscitation is so critical in early septic shock. We're compensating for the preload reduction caused by the vasodilation. In hemorrhagic shock, the compensatory response in hemorrhagic shock, the body attempts to compensate through arterial vasoconstriction. Blood is mobilized from the periphery to the central circulation. This temporarily preserves preload despite volume losses. Cardiac output is maintained longer than otherwise would be possible. Cold, pale extremities signal this compensatory mechanism. How about neurogenic shock? The sympathetic disconnect in neurogenic shock, such as a high spinal cord injury, results in loss of sympathetic tone that causes vasodilation and venous dilation. Dramatic reduction in both afterload and preload. Cardiac output falls due to preload reduction. The classic warm shock presentation, understanding the relationship, guides our interactions and our interventions in vasodilatory states, such as septic and anaphylactic. Fluid resuscitation addresses preload. Vasopressors help to restore vascular tone and mobilize pooled blood in vasoconstrictive shock states. Now, vasodilators may improve organ perfusion, but watch out for preload reduction and falling cardiovascular output. Remember, when you manipulate the vascular tone with medications, you're affecting both afterload and preload at the same time. This dual effect explains why some interventions produce unexpected hemodynamic responses. The resistance vessels are not just controlling the local blood flow, they're constantly redistributing the body's circulating volume between the peripheral and the central components, fundamentally influencing cardiac function in the process. The resistant vessels are not just controlling local blood flow, they're constantly redistributing the body's circulating volume between the peripheral and the central compartments, fundamentally influencing cardiac functions such as preload and afterload in the process. Now, we've all been conditioned to focus on that top number in blood pressure readings. Systolic blood pressure below 90, that's hypotension. But this oversimplification can lead to dangerous misinterpretations. Systolic pressure represents just a brief moment in the cardiac cycle, the peak pressure during ventricular contraction. It tells us about the maximum force, but not about the sustained perfusion pressure. MAP is the pressure that matters to tissues. Mean arterial pressure represents the average pressure driving blood through the systemic circulation during the entire cardiac cycle. It's calculated as systolic blood pressure plus 2 divided by diastolic, or multiplied by diastolic blood pressure divided by 3. Why this formula? Because diastole typically lasts about twice as long as systole. Therefore, the diastolic pressure contributes more to the average perfusion pressure over time. MAP better reflects perfusion sustained pressure. Organs don't care about momentary peak pressures. They need sustained perfusion pressure throughout the entire cardiac cycle. Critical organs maintain constant blood flow when MAP stays between 60 and 160 millimeters of mercury. When MAP drops below 60, tissue perfusion pressure becomes pressure dependent. Despite a patient having a higher systolic, if their MAP is low, their tissues are experiencing lower average perfusion pressure. In conditions like sepsis, aortic regurgitation, or severe anemia, we often see a widened pulse pressure with preserved systolic but dangerously low diastolic pressures. MAP will reveal the perfusion deficit that systolic pressure masks. Recognize that normal systolic pressure doesn't guarantee adequate perfusion. Consider the elderly patient with chronic hypertension and sepsis who presents with a blood pressure of 110/40. Their systolic pressure appears reassuring, but their MAP of 63 indicates that they're on the edge of critical hypoperfusion. The bottom line here is that systolic blood pressure tells us about cardiac ejection force. Mean arterial pressure tells us about tissue perfusion. When it comes to cellular oxygen delivery, the ultimate goal in managing shock, MAP, gives us more relevant physiological parameters. Remember, cells don't feel peaks, they experience averages. While we focus on macro hemodynamic parameters like blood pressure and heart rate, the true determinants of survival exist at the microscopic level. The microcirculation consists of three primary components: arterioles, which are small resistance vessels that regulate blood flow; capillaries, thin single-cell tubes where gas and nutrient exchange occurs; venules, the small collecting vessels that return blood to the venous system. In normal physiology, this network is regulated by autoregulation, or local control of blood flow based on metabolic needs, endothelial function, maintaining the barrier integrity and vascular tone, and specific types of properties that ensure proper blood flow characteristics, as well as an inflammatory balance, controlling the immune response and coagulation. Regardless of the initial shock trigger, whether it's hemorrhagic, cardiogenic, septic, or anaphylactic, the microcirculation ultimately experiences similar pathological changes. In early shock, tissues with high metabolic demands receive preferential blood flow through the autoregulation. As shock progresses, this regional blood flow regulation fails, leading to poor distribution of blood flow, areas of tissue hypoxia alongside of necessary perfusion, and an inability to direct oxygen to the tissues most in need. The endothelium, once thought just to be a passive lining, is now recognized as a critical organ itself. There is a damage to the protective endothelial surface layer that results in the loss of barrier function, leading to capillary leak. As a result of this, we get a production of nitric oxide that causes pathological vasodilation, and it becomes very, very sticky, attracting inflammatory cells. As shock progresses, blood begins to bypass capillary beds through anatomical shunts that direct connections from arterial to venules, and functional shunts that have a flow pattern that changes that reduce effective capillary perfusion. This explains why some shock patients can have warm extremities and near normal oxygen saturation despite profound tissue hypoxia. The blood is circulating but not reaching the cells. The microcirculation becomes a site of pathological clotting. Tissue factor release triggering coagulation cascade that results in the formation of microthrombi, occluding the small vessels, leading into the development of disseminated intravascular coagulation, or DIC. This causes a paradoxical bleeding due to consumption of clotting factors. We see an inflammatory response. Shock triggers an inflammatory cascade that releases of damaged specific molecules that will result in damage of local and distant tissues. The mitochondria dysfunctions at the cellular level. Understanding microcirculatory failure helps explain the clinical progression of shock. That being compensated shock again. Normal blood pressure maintained through compensatory mechanisms, tachycardia as the cardiac output increases to maintain perfusion, peripheral vasoconstriction causing cool, pale skin, microcirculation of an early regional redistribution of functioning properly, and then mild lactate elevation and a normal base deficit. In this stage, patients maintain acid-base balance through respiratory compensation. Watch for your patient's respiratory rate to go up with normal pulse oximetry. When patients move into decompensated shock, hypotension as a compensatory mechanisms begin to fail. Patient's mental status begins to diminish from cerebral hypoperfusion. You have poor pulse quality and diminished peripheral pulses. Widespread dysfunction with shunting in the microcirculation and capillary leak, and our lactate levels begin to rise even more. Transition from compensated to decompensated shock can occur rapidly, often with minimal warning signs besides subtle mental status changes. Leads into irreversible shock. In irreversible shock, only about 5% of our patients can be resuscitated. This results in multi-organ system failure. In the microcirculation, we have complete failure with widespread microthrombi. Our patient becomes severely acidotic, coagulopathic, and electrolyte abnormalities, which result in cell death through necrosis. In this stage, even restoring normal hemodynamic parameters such as the blood pressure, the heart rate, and cardiac output fails to rescue the patient because the microcirculation has sustained irreversible damage. Early intervention is critical. The window for effective intervention closes as microcirculatory damage progresses. Normal blood pressure doesn't guarantee adequate microcirculatory perfusion. Excessive fluid can worsen endothelial damage and capillary leak. Serial lactate and base deficit measurements track microcirculatory function. Remember, our early therapeutic interventions, fluids, vasopressor, inotropes are merely tools to support the microcirculation until the body can restore normal physiology. The ultimate battle between life and death occurs not in the large vessels we can see, but in the microscopic vessels that feed every cell in the body. We're connecting the clinical signs and symptoms of shock directly to their underlying pathophysiology. This approach will help you to understand shock and recognize it earlier, understand what you're seeing, and treat the patient rather than just the numbers. The sympathetic nervous system activation is the body's first line of defense against falling perfusion. The stress response manifests through easily observable signs. One of the earliest and most sensitive indicators of shock is tachycardia. It's mediated by direct sympathetic stimulation and catecholamine release. It allows increased cardiac output despite falling stroke volumes. Expect about a 10 to 30 beat per minute increase even in earlier compensated shock. Vasoconstriction maintains central perfusion at the expense of the periphery. Alpha adrenergic mediated constriction of the resistance vessels results in increased afterload to maintain blood pressure. This redirects blood from the skin and from the unnecessary organs to the heart, the brain, and the renal system. We see skin changes. Temperature gradient from core to periphery may present initially as cool fingers and toes only, and it progresses approximately as the shock worsens. Compare the extremity of the patient to your own skin temperature. We see a sympathetic stimulation of the sweat glands resulting in clammy diaphoretic skin. This is often present despite adequate ambient temperature, and it's most noticeable on the forehead, the palms, and the chest. This comes about as a direct result of norepinephrine and epinephrine release. Pallor comes about as a result of vasoconstriction and reduced cutaneous blood flow to the skin. This is best observed in the nail beds, conjunctiva, and oral mucosa. Could potentially be subtle in darker skinned patients. This represents blood being redirected to vital organs. We also see neurological effects, anxiety and restlessness. These are early compensatory responses because of the central catecholamine effects on the brain. It impairs the perfusion of the cortex, and it can often manifest as inappropriate behavior or unusual agitation. As shock progresses, individual organ systems begin to exhibit signs of inadequate perfusion. The brain's high metabolic demand makes it sensitive to perfusion changes. We see initial anxiety and restlessness, confusion and disorientation, lethargy and somnolence, and unresponsive and coma. The GCS begins to deteriorate, often with subtle changes in verbal response, and it may fluctuate during compensated phases, but we can see a steady decline indicating worsening cerebral perfusion. Even subtle mental status changes in a patient with normal vital signs should raise suspicion for early shock. The kidneys receive about 20 to 25% of cardiac output, but sacrifice perfusion early in shock. Urine output now begins to be reduced as a result of renal perfusion pressure. Activation of the renin-angiotensin-aldosterone system causes an increase in ADH, also known as vasopressin, and it represents the active conservation of intravascular volume. High specific gravity of measuring your urine in the hospitals reflects maximal water reabsorption and may precede actual reduction in volume. We're often asked about recent urination by patients in early shock, and they often report not having to go despite adequate fluid intake. Beyond sympathetic effects, the skin shows direct evidence of reduced perfusion. We can see a delayed capillary refill. Mottling or patchy discoloration of the skin results from heterogeneous microcirculatory flow, and it often begins at the knees and elbows and extends centrally as shock worsens, particularly visible in lighter skinned patients. A patient's respiratory rate increases to compensate for the metabolic acidosis. This is an attempt to reduce PCO2 to normalize the pH, and it often is an early indicator prior to acidosis on your labs. Remember, shock is a clinical diagnosis based on a constellation of findings. Begin to recognize patterns, not just isolated findings. Be sure to trend your findings and trust your clinical assessment over the monitor. Patients maintain normal blood pressure well into the shock progression. By the time hypotension develops, compensation is falling. Bottom line here is don't just treat the blood pressure, treat the signs of perfusion failure. Blood pressure is a late and unreliable indicator of shock. Your hands, eyes, and clinical judgment will detect shock long before the monitor shows hypotension. By understanding the pathophysiological basis of each sign and symptom, you can recognize shock early, intervene decisively, and reverse the progression before it becomes irreversible. Remember again, in shock, time is tissue, and tissue is life. While all shock states share the common endpoint of inadequate tissue perfusion, their initial presentations, physical findings, and optimal treatments differ significantly. In hypovolemic shock, we have common causes of hemorrhage from trauma or severe dehydration from vomiting and diarrhea, potentially from third spacing with patients that have pancreatitis and burns, or osmotic diuresis because of diabetic ketoacidosis. Some of the key clinical findings that we will find will be flat neck veins, clear breath sounds, and occasionally postural vital sign changes. The history will suggest a volume loss, and you can often notice dry mucous membranes and reduced skin turgor. Look for evidence of volume loss in a clinical picture that improves with fluid administration. Cardiogenic shock, this is defined as pump failure leading to inadequate cardiac output despite adequate volume. Most common cause of this is going to be myocardial infarction or arrhythmias that are too fast or too slow. Some of the key clinical findings will be JVDs, pulmonary crackles, peripheral edema, chest pain or dyspnea. The combination of respiratory distress with JVD often strongly suggests cardiogenic etiology. These patients will often worsen with aggressive fluid administration. And obstructive shock, this is a mechanical impediment to cardiac filling or injection. Common causes are tension pneumo, cardiac tamponade, pulmonary embolism, or really severe pericarditis. Some of the clinical findings that you will notice on these particular patients include JVDs, pulsus paradoxus, unequal breath sounds, and muffled heart tones. Obstructive shock typically has a sudden onset with a rapid deterioration. The combination of hypotension, JVD, and tachycardia should trigger immediate consideration of obstructive causes. In distributive shock, an abnormal distribution of blood volume due to vasodilation or endothelial dysfunction. Sepsis is the most common cause. We can also see anaphylaxis, neurogenic shock, sometimes adrenal crisis, or potentially a patient that overdoses on medications that bring about massive vasodilation. With these patients, you'll often see warm, flushed skin, low systemic vascular resistance, normal to elevated cardiac output. Specific clues by subtype of sepsis, you'll have fever leading into hypothermia. Anaphylaxis, you'll have urticaria, angioedema, severe wheezing, and exposure history. With neurogenic, potentially history of trauma. And if you've got a patient that's in adrenal crisis, they've got a history of steroid use and hyperpigmentation. The presence of warm extremities in a hypotensive patient strongly suggests distributive shock. This is the only shock state where vasodilation predominates initially. I'm going to integrate everything we've covered about shock into a unified approach that takes you from recognition to intervention. What makes a great paramedic isn't just identifying shock, it's understanding the specific pathophysiology at play and intervening decisively before decompensation occurs. Your approach to every potential critical patient should include this systemic shock assessment. Look for the constellation of findings that preclude hypotension. Remember, by the time hypotension develops, the patient has already lost significant physiological reserve. Don't wait for the numbers to fall. Next, assess the primary pathophysiological mechanism. Assess your patient's volume assessment, and then this we're looking for our preload. Assess the pump. Determine whether contractility is adequate or not. Assess the pipes. We're looking at afterload here. Distinguish the specific etiology of hypovolemic shock. Go through their circulation, their history, differentiate whether we're looking at cardiogenic, obstructive, or distributive shock that's coming into play. Your intervention should target the specific underlying pathophysiology. Address the preload deficits by crystalloid resuscitation, 20 mils per kilogram of an initial bolus. Consider blood products in hemorrhagic shock and maybe even positioning of your patients. Stop visible bleeding, splint fractures, and in cardiogenic shock, some obstructive shock, judicious fluid boluses may help the patient as well. In cardiogenic shock, control the rate. Treat tachyarrhythmias and support bradycardias. Consider push-dose epi if available. Reduce the afterload, nitroglycerin for pulmonary edema if the blood pressure is adequate. In sepsis, anaphylactic, and neurogenic shock, we use vasopressors after adequate volume resuscitation. Treat the cause of the shock. Antibiotics for sepsis, epi for anaphylaxis. Support cellular metabolism across all shock types. Maintain an SpO2 of greater than 94%. Prevent hypothermia. Check and correct hypoglycemia when it is present. Understanding when, what, and how much to give can literally be the difference between life and death. Before any fluid goes in, remember your assessment. What kind of shock are we dealing with? Hypovolemic, cardiogenic, distributive, or obstructive? What are the vital signs telling us? Look at the blood pressure, the heart rate, capillary refill, and the mental status. Are there contraindications to aggressive fluid resuscitation? Our first-line fluid therapy in most shock scenarios is a 20 milliliters per kilogram bolus, and we're going to reassess after each bolus. Now, your best fluid flavor depends upon the situation. Both normal saline and lactated ringers work, but LR may be preferred in metabolic acidosis as normal saline tends to be acidotic and can worsen acidosis. LR is preferred in hyperkalemia because normal saline can make it worse. Now, there are some warning signs for fluid overload. Listen to your breath sounds early and often. Listen for crackles in the lung fields, JVD, peripheral edema, or worsening respiratory status. Blood products are essential in hemorrhagic shock. Whole blood is preferred when it's available. Packed red blood cells for oxygen carry platelets, and plasma, fresh frozen plasma and platelets for coagulation benefits. The goal isn't just volume, it's perfusion. What we're looking for is improved mental status, adequate urine output of greater than half milliliter per kilogram per hour, normalization of vital signs, improved capillary refill, or lactate clearance. Keep in mind, fluids are a drug. They have indications, contraindications, and side effects. Start with a 20 milliliter crystal bolus in most shock scenarios. Use blood products early in hemorrhagic shock and always reassess. It's not about how much fluid you give, but whether you're improving tissue perfusion. As we wrap up our discussion on shock, let's focus on what matters the most when you're face to face with these critical patients. Shock is complex and rapidly evolving. What begins as one type can quickly become another. Understand the pathophysiology, not just the numbers. Blood pressure of 90 systolic means different things in different patients. An elderly patient with chronic hypertension may be in profound shock at 110 systolic. A young athlete might compensate at 80 systolic. Look beyond the monitor and assess your whole patient. Recognize the early signs of shock. Compensation is deceiving. Tachycardia is often the earliest sign. Respect it. Mental status changes may be subtle initially, looking at like confusion or agitation. Lactate acid elevation indicates anaerobic metabolism is already occurring. Tailor your treatment to the type of shock. If it's hypovolemic, replace what's lost. Fluids, preferably blood. Cardiogenic, support the pump function. Distributive, address underlying cause while supporting the vessels. In obstructive, remove the obstruction as much as you possibly can, such as in like a tension pneumo. Reassess, reassess, reassess. Every intervention demands reevaluation. Be prepared to pivot treatment approaches, know when to escalate care or involve others. You are the front line in reversing shock. Think fast, act faster. Your recognition, your assessment, your actions in these first few minutes to hours will determine if tissue perfusion is restored before irreversible damage occurs. The pathway to survival runs directly through you as the paramedic in the decisions you either make or don't make. Trust your education, trust your assessment, and never underestimate shock's ability to deteriorate rapidly. Remember, in shock management, minutes matter. Make them count.